I seem to be having technical difficulties with the camera here. So, just to recap really fast, dwarfism is not only growth hormone deficiency, but it's also 70% of the time achondroplasia, where the cartilage is not allowing the long bones to grow tall. And what this looks like, we'll see in another slide, is where the person has a normal size trunk in relation to the head, but the long bones, like the arms and the legs, are a lot shorter than they should be. So this is not very good representation, I guess, but that's the arms and the legs are shorter in this case than they could be. Okay, anyway, so that's achondroplasia. There's also decreased growth hormone, and that is also a cause of dwarfism, where just like too much growth hormone was gigantism, decreased growth hormone is dwarfism. Alrighty. The funny thing about achondroplasia, again, 70% of the cases is from achondroplasia, but out of those, we always talk about the autosomal dominant inheritance on this, but actually there's a spontaneous mutation that accounts for almost all of those cases of achondroplasia, not autosomal dominant. Okay, so that's like 7/8 of them, or the autosomal dominant is only 1/8 of the causes or the cases of dwarfism. Okay, it is, you know, not incredibly uncommon, 1 in 25,000 births worldwide, and you should definitely look at the video on the original PowerPoint for the primordial dwarfism. That one is completely different. It only takes 4 minutes. It's not too long. And we're talking, if this is a average height person, and say this is a achondroplastic dwarf, and I guess that would be more, that looks pretty much in relationship to everything, right? So let's go ahead and make the body that long and little bitty legs and little bitty arms, so that's a achondroplastic dwarf. Well, primordial dwarfism is going to be somewhere way down here. Everything is in proportion, but really little. Okay? So definitely check that out, because it's worth your 4 minutes. You probably will never forget primordial dwarfism after that. Some of the signs and symptoms along with it is hip deformities. One of the things that kind of goes along with dwarfism. A club foot. This is what a club foot is it takes a sharp little turn there. And scoliosis and lordosis, we will look at those in a little bit, but scoliosis is where it, if this is a spine supposed to be more or less straight, looking at it straight from the back, scoliosis is deviation somehow, and lordosis, if you're looking from the side, it kind of goes in the lower part way back out. Well, anyway, we'll see that in a minute. Okay, the testing, height percentiles, of course, ever since children are very small, right when they're born actually, you start looking at the height and weight percentiles, and it won't take that long to figure out that that child is not catching up with the normal growth charts. Hormones, of course, check your growth hormone level, even though that's not as common as the achondroplasia part, but the x-rays, clearly you can see when they are not in proportion to each other, and you're also looking, by the way, with the x-rays and CTs for things like the hip deformities and that sort of stuff, and scoliosis and lordosis. And genetic testing, again, autosomal dominant, not most of the cases, only 1/8 of the achondroplastic, but it's something we can check, so that seems to receive a little bit of attention because of that. Okay. Another slide here on achondroplasia. Large head, prominent forehead, normal sized torso is one of the keys with achondroplasia, but the arms and legs are short. Okay. Also, a diverging ring finger, or a trident appearance, is what they call it right there. Intelligence is normal, nothing wrong there, and for whatever reason, autosomal dominant, even though it's well, it's autosomal dominant, or you get a new mutation, and with older fathers, and that has a higher chance of having a new mutation. Really don't know why that is. Okay, cryptorchidism is what we call an undescended testicle. Okay, this is not uncommon, that's for sure, but typically what happens is up in the body of the, I guess I'm going to draw like a actual body of a fetus, I guess, and typically up in the body of the fetus, the testes just start somewhere up in the chest cavity, and they kind of work their way down and drop into the scrotum at the very end. Okay, so 28 to 40 weeks of gestation is when they actually start working their way down to drop into the testes. Well, they don't always do that. Okay, full-term babies, only 3% have that issue where they're not dropping, but 30% of preemies, just because of the timing on this, is, you know, pretty close, pretty exact to when children are being born anyway. Okay, well, even if they do not descend and they're somewhere, testes are hanging somewhere in the abdomen during birth or right when they're born, most of the time they are going to descend. Half of them at least will descend by 3 months, and by 1 year 80% of them are descended, and they will drop into the testes themselves without any surgical help or anything. It's a problem if they do not, because if you don't get that undescended testes into the scrotum, then you actually have to do it surgically, because if the surgery is not performed and they don't drop into the scrotum, then it really increases the chance of testicular cancer. I believe it's not even an increase in chance. I believe it's a, if they do not, it's a when they're going to get testicular cancer. Anyway, causes, don't know. There does seem to be a family history link. Probably has something to do with how a particular family's hormones are expressed, but not really positive on that yet, on exactly. So we have to kind of go with idiopathic for now. Uneven testicular height, if one of them is not descended all the way, and of course that is one of the things that the pediatrician will immediately check, is to see if there's actually testicles in the scrotum. Okay, so that's clinical testing is what you're talking about, and of course you can always verify it with the imaging of whichever you choose to look through to find that. Okay, again, orchiopexy is a surgery to move that undescended testes into there, and a little bit of HCG also helps it to drop. Okay, that's what it looks like if it's simply not there. You can kind of see the testes in here, but definitely nothing in that area. Okay. Hypospadias and epispadias. Okay, hypo is below, epi is above, and what we're talking about here is where the opening is for the urethra on the penis. Okay, so I think we have a picture in the next slide or something like that. Again, idiopathic, maybe a family history link in that, again probably for the same reason as the undescended testes, with hormonal patterns in families. And these are fairly common congenital abnormalities. Okay, so it's not that uncommon for little boys to be born with hypo or epispadias. They are fairly easy to fix as far as this is, you know, all surgeries go. So somewhere between 3 months to a year and a half, the little boy should have the surgery done to fix it. Probably the earlier the better, because that's not really something I think fixes on its own. Okay, so what you'll see again on the next slide, but depending on where the hole, it's an extra hole, or not even an extra hole, but the opening is in the wrong place on the penis. So we'll be able to see that. Let me jump to the next slide so you can actually see what we're talking about here. Alrighty, so if in this case, you know, that would be a hypo spadias, because it's actually there's no hole here where it's supposed to be. Instead, it is down there underneath, and then you would have the epispadias that would just be somewhere on the top that it would have an opening at. Okay. Polycystic kidney disease is kind of an interesting one just because it looks so bizarre. Okay, poly, again, many cysts in the kidney is exactly what this is. It's filled with all of these, cysts, the kidneys are, and it's all over the place. Tubules, collecting ducts all over in there. It's really not that uncommon, 1 in 1,000 live births. This is autosomal dominant, and it's one of those ones kind of like Huntington's where the onset is in adults. Okay, we're talking about 90% this time. So the autosomal dominant factor in polycystic kidney disease is 90% of the time, as opposed to the achondroplasia is pretty much the opposite, right? There's also an autosomal recessive, and that is the one that right after birth or in childhood that you'll start with the polycystic kidney disease. Obviously, you do not want something like that to start young because it only continues to get worse. So what happens if you have a whole bunch of cysts on your kidneys? Then because of so much blood flow goes through that kidney, somewhere around 20 to 25% of your blood flow coming out of your aorta goes through that kidney, you're going to get hypertension because it's blocking the kidney. Remember, it said it's all over the place. It's in the tubules and collecting ducts, so it's going to block that kidney and cause that back pressure and therefore hypertension. Okay, because they do get big, it hurts, and you're going to see an abdominal or back mass in these kidneys because it's quite a bit bigger than a normal kidney. Okay, blood in the urine because of these destroyed kidneys, and for the same reason, you're going to get frequent kidney infections that because of the damage that is happening with these kidneys and its inability to work correctly and keep urine going the correct way. Okay. Along with this are some things that, if you think about, they kind of make sense a little bit. All right. First off, let's look at the higher risk of the cerebral or aortic aneurysms. Again, it's increased blood pressure. So that kind of makes sense, right? If you increase your blood pressure, any place where there's a weak wall is going to be the place that it gives and make an aneurysm. Okay, the mitral valve prolapse, again, it's a high pressure system, and if you're looking at the heart and breaking into its little things here, you're talking about, you know, coming out there is going to the rest of the body through the aorta. And this is the left side of the heart, and the mitral valve is this one right here coming in from the lungs and then going out to the rest of the body. Well, if you reverse that pressure, because there's a back pressure from the kidneys not working, you can see where it can affect that valve fairly easily. Why it doesn't affect the aortic valve so much, I really don't know, but it definitely affects the mitral valve. The diverticulosis, really have no idea why that is associated with it. Usually we're talking about an increased pressure in the system, but with diverticulosis, you're talking about the colon that has an increased pressure inside of it, but I'm not sure exactly how it translates into the colon from essentially an issue that's in the kidneys and blood as far as the pressure goes. Okay, believe me, you can see these on CT or ultrasound really easily, especially if they get really big. And because of that autosomal dominant factor and recessive for that matter, you do want to do genetic testing. Okay, you ready? Okay, now that's some kidneys. Okay, look at the size of those kidneys, and this is this guy's hands. So, can you imagine a normal kidney is probably, say about that big, maybe fit in the palm of your hand. And these suckers are just ginormous. Okay? Let you stare at that for a little bit of while. Oh no. Oh no. Yeah, they're huge. Okay, had enough of that. Let's move on. There's another one. Obviously a gross specimen that is showing all the cysts inside of it. That's just chock full of cysts when it was sliced like that. Sickle cell. Okay, what do we know about sickle cell anemia? Okay, we do know it is genetic, and they are red blood cell disorders. Red blood cells are supposed to be more or less discoid shaped and serve a purpose with carrying oxygen. So you can see where that's kind of discoid shaped, and if you looked at it from the side, this inner part would be a little bit inverted. Anyway, it's kind of like a disc. Obviously this and that are not normal. Okay, they look like sickles or like a crescent moon or something like that. Okay, as far as genetics go, it is autosomal recessive. You see that in African. I don't know if it's necessarily African American because, sorry, hang on. Excuse me. You see that in African descent, more on the continent of Africa. Whether they're American or not is irrelevant. They can be in France for all that matters, because this seems to be an issue that has a lot to do with excuse me, keep wanting to sneeze. Hang on. Sorry. Okay. Has more to do, I think, with malaria, because if you're looking at malaria is carried by little mosquitoes, and the mosquitoes, of course, like blood. So mosquitoes will go ahead and they'll bite you, and when they transmit the malaria, then the malaria really likes to infect the blood cells also. Believe it or not, they can't latch on, or they can't really infect the sickled cells, so it's a protective factor. Okay, now we are talking about sickle cell trait. Okay, sickle cell trait means you have one allele for the sickle cell, hemoglobin S sickle cell, and one for hemoglobin A, which is normal, okay, in this case. So if you have some of the blood is sickled and some of it's normal, then you still have enough normal red blood cells to do the job, but then you have enough of the sickled where it deters the malaria from infecting for very long anyway the person, so they can get over malaria a lot better because it doesn't affect all of their red blood cells. Okay, and it's a sickling of cells. That hurts though, because it causes abdominal and bone pain, as it's especially going through and being destroyed inside the spleen. And that's why they call it a splenic sequestration crisis, because red blood cells are supposed to live about 4 months or 120 days. Okay, well, red blood cells in this case are only living 10 to 20 days because they're getting destroyed every time they go through that spleen. It's clogging up the filter in the spleen. If you can picture, kind of like a filter where the red blood cells are supposed to go through and get recycled or just pass through. These sickle cells, they get caught in that net in the spleen and the filter, and they destroy the filter, they destroy the spleen, and your old red blood cells are running around not nearly as effective as they were, but also it's going to cause it so that you have less blood because of the destruction of these cells as they go through all the time. So you're talking 10 to 20 days as opposed to 120 days. Okay. Also, the sickling of cells will cause ulcerations. You can clearly see where you would have thrombi or infarcts if these, again, get caught and start to clog up different places like lungs or something like that especially. All right. Hemolytic crisis, again, is what I'm talking about here, where you're breaking down red blood cells. And sorry. And that would cause jaundice and blood in the urine because of the breaking down of the red blood cells. Bilirubin is carried. That's a kind of a different subject, but bilirubin gets carried on the is made from breakdown products of blood, and the continued breakdown of these blood, these hemolytic and aplastic crises, will cause the increase in bilirubin and therefore jaundice. Okay, hematuria, just because you are destroying, among other things, the kidneys too, and their filters, just like the spleens. Okay, lack of oxygen, dehydration increases sickling, so it goes from worse or bad to worse. And we've tested basically by looking for the hemoglobin sickle cell trait, or the hemoglobin sickle cells. Okay. Anemia is still anemia, decreased red blood cells, and for treatment, depending on what we're talking about, the hydroxyurea is really interesting, because now we're talking about stimulating hemoglobin F, which is fetal, and fetal hemoglobin, we all start out with it, and it's very, very high affinity to attract oxygen. So if we can actually stimulate some of that in a person with sickle cell, then the blood cells that they do have will be very, very efficient. Okay, and then the hydroxyurea with that. Antibiotics are simply for fighting infections, of course. More pictures of the sickle and normal red blood cells. Scoliosis, we are talking where you see the curve in the spine. See, so if this is the spine up here, and it kind of takes a little curve and goes back, right? So that's scoliosis. It's a lateral curvature of the spine. 98% are right thoracic. They go that way to the right. And there's three kinds. Most of the time we have no idea. 80% of the time it's idiopathic. Sometimes it's congenital, where you only have half of a vertebra or vertebrae, and that would make it go the other way if only half of it is there, which is a bit odd. And then tetralogic. Okay, now we're talking about a systemic syndrome like tetralogy of Fallot that has 4 different things that have to be present, and we'll look at that in a minute here. Okay, neuromuscular, like cerebral palsy, is certainly associated with scoliosis, as is muscular dystrophy and Marfan syndrome. So these are neuromuscular issues, and Marfan syndrome is actually a connective tissue disorder that has more to do with cartilage and things like that than bone, but it could also cause, because of the relationship between cartilage and collagen, actually. All right, signs and symptoms: uneven height. Okay, so shoulders, hips, leg length. Makes sense if you're curved, kind of standing off kilter a little bit there. X-ray, sure, and you have to rule out other pathologies to make sure it's not any of those above that we just talked about. Alrighty, treatment. Sadly, to fix 25 degrees or more, then you're talking wearing a brace for 16 hours a day, and for a 50-degree curvature or more, you pretty much have to fuse the spine. Now, having said that, there seem to be developments in orthopedic surgeries every single day, so take that for what it's worth as far as how current we are on that. Okay, obviously there's a very clear case of scoliosis right there. And these are some of the growing rods. You don't really see a lot of these anymore. As far as the growing rods go, they have more modern equipment, but this was definitely the standard of care in the past, where they literally put rods in there to support. And then of course they would fuse them if it came down to that. Tetralogy of Fallot. Want to finish this up, even though our video is getting a little bit long here. Okay. The tetralogy of Fallot is 4 separate abnormalities of the heart that kind of go together. Okay, so it's a specific congenital heart defect that has 4 things in common. All right, now you have a transposition of the great vessels here. So let me see if I can even show you. That's coming down into the right side of the heart, going up through the right side of the heart. It is supposed to go into, yeah, here we go. That pulmonary valve is really narrow. Okay, so that's one part. The one, let's just do this in order. Why don't we do that way? Okay, ventricular septal defect. Okay, obviously the big parts down here are the ventricles, and there's supposed to be a septum. The septum right here is supposed to go all the way through, but it doesn't go all the way through, separating the right and the left side of the heart. Instead, it actually has a hole in here. Okay, so as you can see from this arrow, blood can get shunted from the right heart into the left. So that's one of the main things. Okay, the aorta gets transposed, so instead of it coming out of the left heart and the blood going into the aorta from the right side of, or left side of the heart back to the rest of the body, that aorta is actually in the right side of the heart. If you look really close there, now that I got my drawings all over the place. So the aorta gets transposed into the right side of the heart instead of where it's supposed to be in the left side of the heart. And then you have the pulmonary stenosis that I said already. Again, it's really, really narrowed of that pulmonary valve. So it's very difficult to get through there. And then the right ventricle gets really hypertrophied. You can see how thick that muscle is right here in the right ventricle. Okay, those are the 4 things with the tetralogy of Fallot. It is congenital. Obviously, it causes cyanosis, difficulty getting oxygenated blood because of the transposition, especially of these great vessels having deoxygenated and oxygenated blood being mixed up together. Okay, difficulty feeding, failure to thrive, means the child is not growing nearly as well as the child should be growing. You get clubbing because of the chronic hypoxia, and could lead to sudden death. Okay, testing. Well, the EKG is definitely going to be kind of messed up. The CBCs, you might be able to find polycythemia as an extra red blood cells. Echocardiogram. That's this. Oh, the echo. I'm sorry. The echocardiogram. You can check out that thing and look at it that way. It's kind of like an ultrasound of the heart. And cardiac catheterization. You can run a catheter up there and trace where it goes, and you can see where the vessels are not going where it's supposed to go. Okay, here's another one. This is probably a little more clear. So if we go ahead and follow it, our blood flow coming from our deoxygenated blood, going back into the right side of the heart, goes up into the lungs, into the pulmonary artery, but where is it? It doesn't even say, but this is pulmonary stenosis right in here, so that's a lot more narrow. Okay, that pulmonary artery goes up, and it is supposed to go into the lungs, which it does. Okay, well, it's supposed to come back from the lungs, and this is also going to the lungs, so that's good. But after it comes back from the lungs, it's supposed to go down in the left atrium, which it does. Goes through the mitral valve, left ventricle. It's supposed to go out to the rest of the body through the aorta. But if you see right here, because of that septal defect, the septum doesn't go all the way up, and some of this deoxygenated blood, instead of going up where it's supposed to go originally through that pulmonary artery to the lungs, the deoxygenated blood mixes with this oxygenated blood that went the right route and then goes into the aorta, and now you're sending half oxygenated and half deoxygenated blood out into the body. Okay? And that ends our Module 12. Sorry for all the technical difficulties. I hope you have a good day.